In pathology, it's all about how much tissue you have. So any technology that puts more tissue on the slide for us is always going to be an advantage. In particular, there's obviously a very wide spectrum of disease in gastroenterology. So both inflammatory and neoplastic diseases, and all of those require as much tissue as possible. The two instances where we see inadequate biopsies are large lesions that you're looking for invasive cancer and submucosal lesions. And we find the jumbo forceps can sample both of those better than the small ones. Tissue depth is very important. What I mean by that is the deeper down it goes, we can say how deep the pathologic process extends. That's very important in cancer. What we don't want, and this is part of the unsatisfactory specimens we sometimes receive with the smaller forceps, is that there's a large lesion and they're biopsying the superficial mucosa. They don't get deep enough. And so we tell the clinician, you have a villus adenoma with severe dysplasia. We do not see the invasive component because it's deeper to that tissue. So those are the types of patients that then need to be brought back. So depth is very important. The jumbo forceps appears to get deeper through the lamina propria into the superficial submucosa, where you can see an invasive neoplastic process. Now there are other submucosal processes too that often create diagnostic dilemmas for the gastroenterologist or the endoscopist and pathology. Those are going to be things like lipomas, carcinoid tumors, gastrointestinal stromal tumors. These are submucosal processes that are often inadequately sampled with the normal small forceps, and the jumbo forceps again seem to grab better tissue. The efficiencies that we gain have to do with how many pieces of tissue we can put in a tissue block. So we have a standard protocol in this institution and some of the in-office pathology laboratories where you limit the number of pieces of tissue you can put in a given block. So say you receive 10 pieces of tissue, that is going to be 2 blocks that have to be processed. Each block has a specific cost associated with it. So if you can take more tissue with the jumbo forceps, and instead of taking 10 small biopsies, you can take 5 jumbo forceps biopsies and actually sample a greater surface area of the colon, you only have to embed and process a single block. So this has tremendous cost savings at a laboratory level when you do that. So that's where we see it on the efficiency side. The financial impact of a rescope is significant. And if we look at not just the laboratory cost, which usually runs between $300 and $500, there's obviously the scope charge, the technical scope charges as well, which run anywhere from $1,300 in a freestanding facility to $2,200 in a hospital environment. So you're talking some significant financial burden at 2% or so that I said that were inadequate or you need to bring patients back. If you multiply that across between 8,000 endoscopies that we perform in this type of facility, that's a lot. But ultimately, it's not really the financial burden, it's the reputation burden. You don't want to be in a situation where you have to explain to a patient that, we have to bring you back. There was one specific case recently where we had a patient that was presenting with GI bleeding, but it was not a primary lesion of the colon, but rather a metastasis from somewhere else. With a small biopsy forceps, they would not have been able to get deep enough into the submucosa to sample that tissue. With the jumbo forceps, they were able to get down and see that this was really a metastatic breast cancer. So obviously that has a tremendous impact on the kind of care that that individual is going to receive.